Thank you very much for having me here today. I'm very pleased to be here in Whitehorse. I've been here a number of times over the years, and you have a beautiful territory, but also northern and rural midwifery and maternal child health is really close to my heart, and I'm pleased we're gathered here today to discuss this. My background is, as you probably can hear, I came 21 years ago from Germany to Canada, and I practiced already 10 years as a midwife in Germany, and when I came to Canada, it was so beautiful, I never turned back. So I also still practice as a midwife, but my main job is teaching these days. And I will be talking to you about models of midwifery models. I know, Joanna, you touched already on it, and I know the whole piece around models will come up in a variety of topics, so some of the things we can just go quicker through as well. Oops, sorry. So I just, being a teacher, trying to establish some learning objectives for you. We'll talk a little bit about the background of midwifery models and how it came about and how we actually reached the kind of model that we have. We will learn about the Canadian model of midwifery care in a little bit more detail and look at the different aspects and how that can also apply to different locations. We'll learn about remote and indigenous programs, not so much from an outcomes perspective, but more how it's working and how this can be achieved, and perhaps also how the model looks differently in those jurisdictions. And I will briefly touch on some of the opportunities and challenges, and I know we have the entire day to review that and have more detailed discussions. So the Canadian midwifery model, really, we've had historically Indigenous midwives practicing in their communities, and it's amazing that some of these midwives were still around in the 50s and 60s. In fact, there is still one midwife on Baffin Island who is still a traditional midwife, and she picks up, an Inuit midwife who picks up her birth supplies from the health center and has continued to practice. But also we had, of course, in the communities, granny midwives, and we had women helping each other in remote settlements. And then, of course, in the 70s, a midwifery movement started. Women were looking for different birth choices and options, and midwifery care began. Of course, then there was no regulation, as Joanna also pointed out, so midwives were community midwives, and I understand you also have some community midwifery occurring at this point in the Yukon as well. So really, it's those two foundations of traditional midwifery, Aboriginal midwifery, that formed the foundation for the currently existing Canadian model that I will be going in more detail into it. And of course, the model is based on evidence, clinical current practice, and so it looks quite different from what sometimes people think about midwifery or think what midwifery is, and often people are surprised actually how midwifery today in Canada looks like. And some of the information we talked already about, that the Yukon is one of the last jurisdictions that has no midwifery, and in fact Canada was one of the last countries, industrialized countries, to regulate midwifery altogether. So some of you may really be asking, well, why do we actually need midwifery? Why can't we just say, look, we have a system that works well? But in fact, really, and some of the speakers and also the ministers mentioned it as well, it is really also about women having choices and the ability to have healthcare providers work together, and having a profession like midwifery become part of your maternal child health system. So it has been an important step in many jurisdictions, and it has been an enormous learning for all of us to work together and really a growing process, I think, both for the midwifery profession as well as also for the other professions as well. And jurisdictions and programs that are working well with different providers together and have an interprofessional relationship. Most of them do not want to go back. People really feel that was the right step and a great opportunity to moving forward. So we'll be asking some of the questions later, like what are the opportunities, for example, in rural Canada and in small communities for Indigenous, where many Indigenous women live, and how care can be provided in those communities. I also just wanted to point out that the SOGC also supports the midwifery care as part of maternal child health care in their position statement, as well as midwifery care in First Nations and other Aboriginal communities, and really values the contribution that midwives are making in those communities. I'll go a little bit more in detail into the 7 core principles of the model of care, and it's a bit of a busy slide, but I didn't want to leave any of them out, and I'll briefly touch on them. So we talked already about the professional autonomy. Midwives are primary care providers, so women can, as you heard already, self-refer. Midwives for low-risk clients can continue to provide the care throughout, but will, of course, work with other providers as needed. Midwives really create sort of a unique partnership with their clients that is professional yet personal care, and women who have received midwifery care really enjoy this approach to care. Continuity of care providers, either midwives work in small groups, sometimes 2 to 4 midwives. Sometimes there are also single midwives, single providers who work with other practitioners such as nurses, and we'll hear later how nurses and midwives can work together. But sometimes also midwives work with physicians together in practices and collaborative models as well, and share care for clients as well. So there are lots of different opportunities and ways how midwives can work with other providers. Informed choice is, of course, something that you have also in every other profession, but informed choice is integral to midwifery, and in particular also to informed birthplace choice. So, and midwives in Canada cannot just work in hospital or can just be home birth providers. We have to offer the full range. And that can change from practice to practice. In my practice, when I was in the Northwest Territories, we were only in a level 1 hospital. If women had to be transferred out, then they were transferred to a physician. But if you work in a larger setting, you have the opportunity to, with hospital privileges, to assist women at home, sometimes in birth centers if that is available, but also in hospital as well. Midwifery practice is evidence-based, and I think that is something that is perhaps more newer to some people who have not worked with midwifery care, with midwives, and may not really understand how midwifery works. And in many ways, midwives have to follow the most current guidelines. Midwives will also follow hospital policies and, of course, also follow college standards, and are highly accountable healthcare providers. And as I mentioned already, collaborative care is an option in many different ways. And there is really a lot of room for flexibility how midwives work. Of course, we consult regularly with obstetricians, family physicians, and other specialists, but we also refer people to physiotherapists and others, whatever our midwifery clients require. But also, again, collaboration may extend way past just a consultative relationship, and over time, really trust builds when people work together, and I think that is very important when you introduce midwifery. I wanted to focus a little bit on northern models because they can be a little bit different, and as Dr. Jansen pointed out already, there are some really unique models out there. And I think one of the most important things perhaps here is that each of these models are so different and unique, and how services are delivered, and yet some things are so similar and really alike. In the north, sometimes midwives can work in expanded scope, and you see that in some of the jurisdictions where, for example, woman care, baby care is included. In the Northwest Territories, for example, midwives can provide postpartum care up to 12 months and are much longer involved in care, in breastfeeding support, in postpartum depression screen, in contraceptive support, and many other areas. And of course, the birth numbers in smaller communities are less, and so it's a great opportunity for women to receive care from their midwives in other aspects other than prenatal care, interpartum care, and postnatal care. Of course, altogether, we still practice within the Canadian model of care, but we sometimes adjust that model to some degree, and perhaps in the afternoon in our working groups we can go into much more detail on that. Of course, the support for birthing closer to home, it was also mentioned already this morning, is something of consideration. It needs to be looked at really carefully, because birthing in the community, and I'll go into more detail on that, requires quite a few things that need to be in place to make that happen. And it may also not be your first priority if you're looking at introducing midwifery either. It will perhaps come over time, and it may not be possible in all communities, because some communities are very small, the birth numbers are not very large, and you may not be able to have midwifery care in those communities. But there are possibilities to still include midwifery in that, and I'll mention that in a moment. We talked already about remote programs. I just thought you might enjoy to see how many remote maternity and midwifery programs exist in Canada, and they're actually growing quite rapidly. The oldest or the longest existing one is the one in Inukjuak. There are 3 communities who provide services in Nunavut, also Rankin Inlet, Cambridge Bay, and Iqaluit. Manitoba, the Pass, and Norway House. In the Northwest Territories, Fort Smith was the first practice, but now a second practice has opened in Hay River, and Yellowknife is currently in the process of hiring midwives to set up a territorial program in their capital. Attawapiskat in Ontario, that has been quite a bit on the news for other reasons, has also a midwifery program. High level in northern Alberta, there is one midwife, and we've been, in my 2 years at Alberta Health Services, we were able to integrate that midwife into a level 1 facility with family physicians there. And of course in BC, and Joanna, you would know more about this, Haida Gwaii has a rural midwifery practice, and there are a number of other rural midwifery practices that are actually growing and expanding there as well. You may ask yourself whether it's safe, you know, if you actually consider birthing away from a level 1 facility. The SOGC and evidence has certainly demonstrated that it is safe, but again, there are a lot of considerations that go into this, and it's not easy just to say, oh yeah, let's do this. It also takes years of time to really plan this. I've had in the early 90s the opportunity to work in Rankin Inlet for a number of years, and we were able to return a birthing program for Inuit women to that community. But it's not an easy process, but it's certainly a consideration, and I think it's good to have conversations and to look like what birthing options look like in a territory, and what is the best decision. And of course, it's also important to include women and communities into that discussion as well. Here's a couple of thoughts about why we would consider such models, because some people may think, well, it's crazy. Everybody should just birth in the center and make it the safest, and they're close to a larger center with C-section backup and so on. Continuity of care for women is very important. Known care providers, Joanna mentioned that already, but specifically if you have populations that may have different needs, continuity of care can make a big difference in building trust and also in health outcomes as well. I mentioned already different and flexible models are required. Community midwifery in smaller communities is one option. Midwifery, of course, in your larger center is another option as an add-on service. But in the Northwest Territories, for example, they are looking now at a territorial midwifery model where a couple of midwives are stationed in Yellowknife, and they will actually do an outreach program with the communities. They will support and work with the nursing staff there. They will see together clients, they help with education, and they will also take care of some of these women when they arrive in Yellowknife to give birth. And do some postnatal care and get them on their way. So there are a number of options, and again, each province, territory, each location is unique, and it's very important to look very individualized at these things. Just a couple of information, and then I'm almost done, about community birthing. One of the things that we identified, and having been involved now in a couple of programs that return birthing to communities where there hasn't been, very important that there is a community interest there. You want to see what do women actually want in that community and what is important for that community. But also the capacity at community level. Interesting, in most of these places there were midwives and folks who were really interested in the topic and kept on pushing and weren't going away, and then things started moving ahead to some degree. There also really needs to be support from health providers, from administration, from the government, but also really from the referral center. And I think people really need to sit together and have those conversations, what is possible and what isn't possible, and what are people willing to do and what people aren't willing to do. Of course, midwifery legislation needs to be in place. If you want to have midwives in a community, in smaller communities, you won't be attracting midwives just to be community midwives, and to really make an impact in that community. You want to have them involved as an active participant and partner with the other healthcare providers, such as the nurses and the physicians there. And of course, the question of funding needs to be raised, and that is, I understand, something that we'll be chatting about in the afternoon as well. So in summary, really, midwifery care can make a significant contribution as part of your healthcare team. And while we see a lot of challenges and those need to be addressed, there are a lot of opportunities to add additional providers. Midwifery care is really also flexible, and so there is an opportunity to look at also at really different models and adjusting your model to not to break away from the essential parts of what makes your model, but to be flexible enough to serve that community and to meet the needs of the women in that community. Regulated midwifery is a real opportunity and will really make everyone grow together. So we see, of course, a lot of, for us who have been in midwifery for a long time and have seen non-regulated midwifery and have seen places where there was no midwifery, we see a lot of benefit to it to have midwives part of the healthcare team. We know, Dr. Jansen spoke already about outcomes. We know that midwifery care is safe and that we have good health outcomes. And there's a real opportunity to bring midwifery to indigenous communities, and that does not only always means that there has to be birthing in the smallest communities. This is something that would have to be really looked at carefully, how that could play out. Before I let you go, I just wanted to tell you that I came in '95 here to Whitehorse, and I assisted a very close friend of mine with her baby at home. And I recall then that we had conversations with community leaders, with the government, with women in the community, because I stayed a while, about the opportunity and the option of regulating midwifery. And I just wanted to congratulate you, because I think that Yukon has really come a long way in now sitting here together and discussing actual concrete options how to bring midwifery to this territory. Thank you very much.
Questions for Gisela?